we'll quickly cover the injuries to the pelvis. If this is the sacrum, this is the pelvis of one side, and this is the pelvis of the other side. The greater sciatic and the lesser sciatic notch. Here you have the acetabulum in the head of the femur and the trochanter. Then the pelvis will be injured. If there is a lateral pressure on the trochanter, there will be a central fracture dislocation. And this will be when the person is lying on the road like this and the crush injury comes like this because of the tire of a truck passing over this. Then there can be an antero-posterior pressure. If the person is lying like this and there is a pressure because the truck tire is passing like this, then this pubic symphysis will fracture on both sides and go inside. And this is called as a butterfly fracture because this is the pubic symphysis. Here is the obturator foramen and it's ruptured from here and here and here and here, and it has pushed inside, and this causes the bladder injury. Most common cause of bladder injury. So a pressure like this, a butterfly fracture, can happen. The third thing that can happen is a pressure on the anteroesophageal spine. If he is lying oblique and one of the anteroesophageal spine is pushed backwards, then if this is the sacrum, here is the ilium. On this side you find that this is the pelvic rim and here is the pubic symphysis, and this is being pushed backwards, so this will open like a book. So there will be a diastasis of the pubic symphysis. This will move this way, and there will be a subluxation of the sacroiliac joint. So this thing will move like this. So this type of fracture dislocation by pressure on anteroesophageal spine is called as open book fracture dislocation. The fourth thing is that if there is a vertical force passing like this, he's fallen on the single limb, then the minor tie beam will break and the major tie beam will break, and this whole half of the pelvis will move up in relation to the opposite half. You will have a shortening of this limb as compared to the opposite limb, and then you must pull this down to reduce this fracture. You must pull this upward moving half of the pelvis down to reduce these fractures. So this is the mechanism of injury and the type of fractures that you see. Now as soon as you suspect such injury because of the mechanism of injury, crushing injury of the pelvis. And the crushing can be from antero-posterior, can be from the side, or can be on the ASIS, or can be on the pubic symphysis. So depending on that, you suspect that particular type of fracture. The first thing that you have to do is stop bleeding, and this you do by reducing the pelvic volume. And basically the pelvic volume is reduced at the roadside. If this is the pubic symphysis and here is the sacrum, by tying a pelvic binder. You can use a dupatta and tighten a pelvic binder so that the open book closes, the volume in the pelvis is reduced. In very less bleeding, the pressure here outside the blood vessel increases and the bleeding stops. This is called as creating a tamponade effect. So pelvic binder, or you can use an external fixator into this and this side of pelvis, and this external fixator can be compressed anteriorly, to reduce a open book fracture and reduce the bleeding. So stop bleeding suspect shock and treat it by replacing blood by blood as soon as possible and as fast as possible, and you monitor shock. After this problem of shock is over, you get into the problem of rupture of the bladder. So rupture of the bladder can be intraperitoneal, when there will be no bladder, he will not be able to pass urine, or he will have hematuria. There will be no bladder palpable or percussible or seen by ultrasound, and you will have fluid in abdomen, which may lead to paralytic ileus and peritonitis, because the urine may irritate the abdomen. And the basic thing is that you will be able to see the fluid by ultrasound and by shifting dullness. Now, an intraperitoneal rupture has to be repaired in a laparotomy, exploratory laparotomy. Then there can be an extraperitoneal rupture when there will be a suprapubic collection of urine, but the peritoneum will be free, but again you will see no bladder, or not feel nor percuss nor see by ultrasound. The third thing is that there is a prostatic urethra here, and then in the deep perineal pouch you have the membranous urethra surrounded by the external sphincter. Then in the superficial perineal pouch you have a perineal urethra and you have a penile urethra. So the third thing that can happen is that there is rupture of the membranous urethra. Now when that happens, per rectally or per vaginally you will not be able to feel the prostate or the bladder. And what you have to do a suprapubic cystostomy in the emergency period. In the definitive operation, you have to pass a Lister's bougie, take it out in the perineum here. Then you have to pass a catheter and take it out of the perineum here. Here you have to tie the end of the catheter to the Lister's bougie and draw it back into the bladder. So this is called as railroad method. Okay, and then around the catheter epithelium will develop and you will have a new membranous urethra, and there may be a stricture which you may have to dilate by repeated passage of Lister's bougie through the penile end. So that this is the repair of the rupture of membranous urethra of the bladder. Then we move on to the third problem in fractures of the pelvis. The third problem in fractures of the pelvis is, you see this iliac crest, you see the posterior iliac spine, posterior iliac spine, greater sciatic knock, ischial spine, ischial tuberosity, and on this side you have the pubic symphysis. Here you have the obturator foramen, and here you have the acetabulum. Here you will have on the inside you will have the auricular process in which will articulate the sacrum, and the sacrum will transmit the weight from the lumbar spine, and this weight will come either on the posterior column, posterior to the acetabulum, this is called the posterior column, or it will go to the pubic symphysis, which is called as the anterior column. Now, then between these two columns, the weight would come to the head of the femur, which will be in the acetabulum, the neck, and go on to the trochanter and on to the shaft of femur. Now, the fractures of the acetabulum can be of the posterior column, can be of the anterior column, can be only marginal. So there can be a marginal fracture, there can be a column fracture, and this column fracture can be anterior column, posterior column, or both. So you will have to deal with a marginal fracture only if it is producing instability. So a posterior marginal fracture can produce a recurring posterior dislocation of hip, and only then you have to repair this marginal fracture or create a bone block so that there is no recurring posterior dislocation of hip. The column fracture, since it involves the articular process, it can produce osteoarthritis. So to prevent it, you have to open, reduce, and internally fix such fractures, so that there is an absolute good alignment of the articular cartilage and there is no osteoarthritis later on. Still, if in a neglected case there is osteoarthritis, you have to do a total hip replacement. Okay. So this broadly deals with the fractures, the anterior and posterior column or both, but the surgical approaches to the anterior column and the posterior column have to be understood. The surgical approaches is ilio-inguinal up to the pectineal eminence, and this Stoppa's approach if you have to approach the medial part of the pectineal eminence and save the vessels. So it can be ilio-inguinal under the anterior-sphenic spine and under the inguinal ligament, or what is called as the Stoppa's approach, when you have to approach the medial part of the pectineal eminence by lifting up the pubic tubercle and the attachment of the inguinal ligament from the medial side. Okay. The posterior column is always approached by Cocker-Langenbach approach, which is the standard posterior approach or Ostenmoor approach, which you have done for fracture neck of femur. So this in short is the management of fractures around the acetabulum.